Okay, let's move on. I want to talk about four-drug regimens if we're looking towards the future. And Peter, I'm going to stick with you because you're the lead investigator on the GRIFFIN clinical trial. Can you just tell the audience briefly what the trial is all about and what you found?
Sure. So this was a randomized phase 2 study looking at the addition of daratumumab into the RVD backbone for transplant-eligible myeloma patients. They received 4 cycles of RVD induction, transplant, 2 cycles of post-transplant RVD consolidation, and then they went on to LEN maintenance until disease progression. The DARA arm received daratumumab both with induction, consolidation, as well as the first 2 years of maintenance therapy. And what we found up to this point is that by the end of consolidation therapy, the stringent CR rates and the CR and non-stringent CR rates are better when you add daratumumab into the RVD backbone. We've also shown an increased rate of MRD negativity with the addition of daratumumab as well. At this point, with close to 2 years of median follow-up, progression-free survival is very good and similar between the 2 arms of the trial. So we have yet to see a progression-free survival advantage with the addition of daratumumab, but we clearly have shown an improvement in the depth of response.
So Tom, are you using 4-drug cocktails yet?
Unfortunately, we're not able to do that due to insurance purposes. I do think that we are going to all move to 4-drug regimens, especially in the transplant-eligible population, and that we're going to get a very deep remission in 3 to 4 cycles and then go right to transplant, just like was done in the GRIFFIN study. So I do think that's the wave of the future, is to try to get an even deeper response using 4-drug regimens quicker. But right now we can't do it just from insurance purposes.
And when you say that, there are FDA-approved regimens that contain 4 drugs from the ALCYONE trial, and I think Cassiopeia too. So just, these are drugs for the audience that using melphalan or thalidomide as one of the 4 drugs. Is it because all 4 drug combinations or just the one that Peter talked about?
That's a great question. In terms of, the ALCYONE trial, using melphalan as a frontline therapy induction is certainly in a transplant-ineligible population. And I do think that the MAIA study with a 3-drug, to me, looks more impressive than a 4-drug regimen using melphalan and bortezomib instead of lenalidomide. So I would still go with the 3-drug with DARA as frontline. In terms of thalidomide, as part of the therapy, geez, I don't think I've used thalidomide since maybe 2004 or 2005, and I'm not ready to go back.
There's the other panelists, anybody more been better able to use 4 drugs, and are you, and if so, and who?
We've only used it in trials. I think right now we're sort of holding back and seeing. I think one of the things that we've noticed in some of the trials, and I don't know if the other panelists have, is that at least our impression in some of the DARA-containing regimens that there's a little bit more difficulty with stem cell collection. I don't know if other people have noticed that, but it just seems sometimes we're using, taking a little bit more time to collect stem cells.
I've seen some data on that, which seems to suggest their yields are lower, but still quite adequate for transplant most of the time, right?
There's a higher rate of use of plerixafor in combination with GCSF for mobilization. And as long as you're doing that, the stem cell yields are similar. They're a little lower, but it's not a clinically significant difference. And time to engraftment is about the same. But if you do go beyond 4 cycles of 4-drug therapy, whether it's RVD-DARA or KRD-DARA, you're potentially asking for trouble. So I would definitely collect after 4 cycles.
Good, that's an excellent point to make. Nupur, what's happening in Boston? Are you moving to 4 drugs?
Not quite. So we're doing that in the context of clinical trials for a lot of the reasons which all of the panelists have mentioned. But I just want to put one thing out there. We are all using 4-drug regimens, and sure, 4-drug regimens are going to show us a depth of response. I think what we need to start doing is using that depth of response to really tailor therapy in these 4-drug regimens, because along with deep responses comes 2 things, both real toxicity to our patients and financial toxicity as well.
So you know, I have had a bit of experience. I did, when I was still at Mayo Clinic, we started using 4 drugs for our younger, higher risk patients. I must say, I didn't find it easy. I think the you know, infection rate and other complications in my early experience was fairly high. So I think we do need to approach with a little bit of conservatism and wait for final results from Peter's work.